So in this video we are going to discuss about thyroid in pregnancy. So what are the changes in thyroid gland during pregnancy? First we are going to see that the size of the thyroid. If you see the size of the thyroid, it is increasing, but this is not due to goiter, so there will be no goiter in the pregnant female, but the size of the thyroid gland will be increasing. But goiter is pathological. If goiter is present along with thyroid, then goiter will be pathological. But both goiter and thyroid increase in size of thyroid cannot be seen together. Next, coming to level of HCG. If you see the HCG levels, they are raised in the case of thyroid. When the HCG level is normally raised because of pregnancy, right? So this HCG level, especially its alpha unit of HCG is similar to TSH. So because of this, there is rise of T3 and T4 also. So HCG level is increased because of pregnancy, but this HCG, it's having alpha and beta unit. The alpha unit is similar to TSH level. So because of this, there is increase in T3 and T4, especially during pregnancy. Now coming to thyroid binding globulin. As this T3 and T4 are increased, even the thyroid binding globulin levels are also increased. As these levels are increased, the free T3 and T4 are normal because they will bind with this, and hence euthyroid is seen during pregnancy. So euthyroid is seen in pregnancy. Now coming to TSH, that is thyroid stimulating hormone. It may be normal or sometimes slightly decreased. Next, coming to iodine requirement. So let us write here, thyroid stimulating hormone may be normal or slightly decreased. And next, iodine requirement is increased during pregnancy. Iodine requirement is increased. The reason why there is increased iodine is because there is increased iodine excretion in pregnancy. So if whatever iodine you take, it will be excreted, so that's why we need more iodine in pregnancy. And RDA of iodine is, there is the recommended dose of iodine is 250 microgram per day. So for one day we need 250 micrograms of iodine, especially during pregnancy. Now coming to hyperthyroidism in pregnancy. So hyperthyroidism, the most common cause of hyperthyroidism in pregnancy is Graves' disease. So hyperthyroidism, most common cause in pregnancy is Graves' disease, which is an autoimmune disease. And there is also HCG mediated disease. Like, why HCG mediated? Because HCG is rise during pregnancy, so there are HCG mediated hyperthyroidism disease like molar pregnancy. So molar pregnancy is also a cause of hyperthyroidism in pregnancy. So now coming to diagnosis. So how to diagnose is the hyperthyroidism, that is T3 and T4. When T3 and T4 levels are rising, then you can diagnose the hyperthyroidism, whereas TSH level is dropping here. TSH level drop to less than 0.1. The level of TSH may be less than 0.1. Now coming to management. So how to manage the hyperthyroidism? There is a medical management. So if medical management, like we give different drugs. So if there is no medical management, if some patient is not responding to medical management, then there is surgery, that is, we do thyroidectomy, that is we remove the thyroid. But in this surgery we need to remember one important thing, that the radioactive iodine is not used in this surgery because this female is pregnant female. So in the normal thyroidectomy we can use radioactive iodine, but especially in pregnant females, radioactive iodine is contraindicated. So now coming to the medical treatment, like what drugs we are using in pregnancy for thyroid, especially hyperthyroid. We use propyl thiouracil. So propyl thiouracil is a drug, but because of this propyl thiouracil, if you use this for the long term in the pregnant female, it may lead to hepatotoxicity, that is the liver may get damaged because of this thyroid drugs, especially if you use long term in the case of pregnant female. And the another drug is Methimazole and Carbimazole. So these are the both drugs which we use, Methimazole, Carbimazole, and this both drugs like Methimazole, Carbimazole and also propyl thiouracil, these three drugs can easily cross the placenta. So when they can cross the placenta, even they can enter, so the drug which mother puts can also enter into the fetus, right? So this may cross the placenta. So this methimazole and carbimazole, what it does as a side effect to the baby when the mother is hyperthyroid, when the mother is having hyperthyroidism in pregnancy, is this methimazole and carbimazole may cross the placenta and lead to aplasia cutis in the baby. Aplasia cutis is a disease where in a hair you will see a patch where there is no hair, that is like a patch around the hair, at the center of the hair where there is no hair. So this is called as aplasia cutis, which is seen in a fetus. And there is also another problem like choanal atresia and also esophageal atresia. So these are the problems which you see especially in a fetus who is having hyperthyroidism mother, because this mother will use all these drugs like propylthiouracil, methimazole or carbimazole. Especially methimazole, carbimazole have these side effects. In the case of propylthiouracil, it will lead to hepatotoxicity. So what is the drug of choice? So as these are many side effects, so what drug is best drug of choice for the hyperthyroidism in pregnancy? That is the propylthiouracil. Why? Because propylthiouracil, we have seen that only if you use for long time, then it will lead to hepatotoxicity. So this drug also we should monitor and give it only for the short time during pregnancy, that is propylthiouracil. And what is the drug of choice, especially in first trimester? Here we need to see that in the first trimester we will give propylthiouracil. Why we are not giving carbimazole, methimazole? Because they are having side effects, and you know in the first trimester only the baby start developing the hair of the baby, so every organ, everything will be start developing from the first trimester. So it's better to give propylthiouracil when compared with this methimazole, carbimazole, because they may cause severe side effects. So what is the drug of choice in the second or third trimester? So from second or third trimester, you know, almost all the organs are formed. So now even you give methimazole, carbimazole, you will not have side effects. So this is very important. In first trimester we should use only propylthiouracil. From second or third trimester you can use any drug like propylthiouracil or methimazole or carbimazole, because even though now the side effects are present in this, even though they cross the placenta, now already the fetus is developed well, so now these drugs can't give any side effect. So now coming to complications common to both categories, that is you see transient leukopenia. You see transient leukopenia, which is in 10%, but you can neglect this effect because it's not that much, only 10% transient leukopenia. And there is also agranulocytosis, but this is very serious complication. Whenever you see agranulocytosis by using these drugs, then immediately we need to stop the treatment, because agranulocytosis is a very severe problem in a fetus and also mother. Next, coming to can cross the placenta, that is fetal hyperthyroidism in goiter. Sometimes actually if you give this treatment to the mother, because mother is having hyperthyroidism, so to treat the mother you give this treatment, but what happens is this, as these drugs can cross the placenta, in the fetus they will lead to fetal hypothyroidism. So still the fetus is not even coming out, but still she is having hypothyroidism because of mother, because mother is having hyperthyroidism, she is using these drugs, and because of these drugs the fetus is getting now hypothyroidism and also goiter. So this is another side effect of these drugs. So what is the aim of treatment to maintain low degree of hyperthyroidism in mother? So one thing you need to remember, here in the case of hyperthyroidism in pregnancy, we are not going to treat this hyperthyroidism completely, only we are going to manage this, only we are going to put the mother on low degree of hyperthyroidism, because if we completely treat this disease in mother, what happens is it will lead to complete hypothyroidism in the fetus because of these drugs. So only we'll give light like only small doses of drugs, so that the fetus may not have problem because of mother drugs. So now coming to TSH levels in the mother will be like about 0.1 to 0.3, and the patients who don't respond to medical treatment have increased chance of PIH and heart failure. So sometimes the patient may not respond to this drugs of thyroid, so then they may have increased chance of PIH, that is pregnancy induced hypertension and also heart failure. So maternal hyperthyroidism during pregnancy can cause fetal hyperthyroidism and also fetal hypothyroidism. So because of mother, now the child is also getting hypo and hyper both thyroidism. So coming to thyroidectomy, that is cutting of thyroid gland. It is done only in non-compliant patients or non-responsive patient. Mostly we don't do it. Only if the patient is not responding to this all drugs, then only we do this process. So what is the best time for thyroidectomy? The best time is second trimester. In second trimester we can do thyroidectomy if the patient is not responding to this drugs. So now coming to thyroid storm in pregnancy. What is thyroid storm? This thyroid storm is very rare. Thyroid storm is rare, and this is most common cause of this thyroid storm is again Graves' disease, which is an autoimmune disease. So what are the signs and symptoms of thyroid storm? You will have fever, you will have tachycardia, you will have altered mental status, nausea and vomiting, and also cardiac arrhythmias. So these are the symptoms of thyroid storm: fever, tachycardia, altered mental status, nausea, vomiting, cardiac arrhythmias. And what are the triggering factors? So in this mother, if there is any stressful event, any surgery, any labor, any complete mole, like whenever HCG is increased during suction evacuation or infection, these all may trigger more this thyroid storm. So what is the management of thyroid storm? So for thyroid storm, the management is beta blockers. Beta blockers like propranolol, metoprolol. So these are used but only for short term therapy. Okay, propranolol and metoprolol only for short term therapy. So now coming to another drug, that is thioamide. You can also give thioamide and corticosteroids. What corticosteroids do is they inhibit the T4 so that they'll convert T4 into T3. That is the main thing which corticosteroids does. So this is about thyroid storm. Now let us discuss the last thing, that is hypothyroidism. So before we discuss hyperthyroidism in the mother, now we are going to discuss hypothyroidism in the mother. So if the mother is having hyperthyroidism, how to treat it and what happens to the fetus, let us see. So hypothyroidism mother in pregnancy, the most common cause is iodine deficiency. So here, because of iodine deficiency, the mother is getting this disease. Especially this iodine deficiency is seen in developing countries, whereas in already developed countries, the iodine deficiency is mainly due to Hashimoto thyroiditis. Hashimoto thyroiditis. And the symptoms are like same in pregnancy and non-pregnant states. So that's why we will confuse, because nausea, vomiting, weight gain, these are all like similar to normal pregnant symptoms. Like nausea will be in normal pregnancy, vomiting also will be, weight gain also will be there. But even in hypothyroidism you are finding the same symptoms. Then how to rule out whether it's hyperthyroidism or normal pregnancy? So for that, the one important is cold intolerance. So if you see cold intolerance is seen only in hypothyroidism. So by this you can rule out that this is hypothyroidism in mother. So what happens here is the fetus is dependent on mother's thyroxine for brain development. Normally in any pregnancy, normal pregnancy, the fetus is developing from thyroxine of mother for the brain development. So now here in this case, the mother is only not having thyroid properly, that is hypothyroidism. Then now there is a chance for fetal brain in development, like there will be some abnormal brain development in the fetus. So even though fetal thyroid gland produce thyroxine from 12th week, so this is important, fetus will start producing its own thyroid from 12th week. The female with hypothyroidism on thyroxine increase the dose of thyroxine by 20 to 30% during pregnancy. So what we need to do is, as this mother is having hypothyroidism, we need to give artificial thyroxine to this mother, and also we need to add some extra 20 to 30% to this mother, because this extra 20 to 30% should be going to the fetus from the mother. So in the treatment of this, we will give extra 20 to 30% during pregnancy. So what is the diagnosis for this? Whenever you see the TSH is increased and T3, T4 are dropped, this is clinical hypothyroidism. Whereas when TSH is increased and T3, T4 are normal, then this is a subclinical hypothyroidism. So what is subclinical hypothyroidism? It always measures the thyroid peroxidase antibody level. So always measure thyroid peroxidase antibody levels. So now let us see the management of hypothyroidism. Drug of choice is levothyroxine. So use levothyroxine starting at 100 micrograms per day, and it should be started at first trimester. So you should begin this by first trimester. The screening for thyroid disorders is not universal in females. It is recommended if female has family history of thyroid disease or any previous history of thyroid disease in pregnancy, or if the female is obese, then you can say she may have hypothyroidism, or if the female age is already greater than 30 years, then you can suspect this. And also to screen serum TSH levels are checked especially in the first trimester. So these are all the important things which we need to see in hypothyroidism in pregnancy. So by this we completed the thyroid disorders in pregnancy. Next we'll start with SLE in pregnancy.